with White Plume. Thank you again for your time this afternoon. I hope this webinar will be helpful for you. This webinar is really the second in a series, so hopefully you have been to our post-ICD-10 webinar where we talk about some of the risks to physician practices post-ICD-10, specifically the risk to physician productivity and cash flow as the payers start to crack down on some of those unspecified codes in ICD-10. Just a reminder of what we're trying to accomplish in the next 45, 50 minutes, our goals for today. The first one is to a review, really to answer the question that you may have or some in your group may have that says, wait a minute, why are we still talking about ICD-10? I thought that was something we did in 2015. I didn't have to worry about it in 2016. So I'm going to go back through that for you quickly, looking at what the short-term and long-term risks are to your practices as a result of ICD-10. So we're going to talk about that. We talked about that in the last webinar, so we'll do a little bit of review there. Hopefully most of you have already done your unspecified analysis. If you need another copy of that, if you haven't seen that, or maybe you didn't go to the first webinar, let Shelley know. You can use the questions panel for that to let her know, and we'll make sure that we get that report to you because we're going to be going through that in detail today. It says, now that I know my numbers, now that I know my data, what do I do next, right? And then what steps can I do to prevent the use of those unspecified codes? What steps can I take to correct some of those unspecified codes so I don't have some of these negative consequences that we're going to talk about? We'll show you how to do that in Excel Capture, or in Excel Mobile, or in Excel Smart. In our White Plume product, how do I leverage what we already have to make my practice perform a little bit better? So we're going to go through that. Again, I mentioned I'll make sure that we leave time for questions and answers at the end. But don't wait to ask those. If you've got questions, you want to use the questions panel, Shelley will answer as many of those as we go, just to make sure that everybody's keeping up. I'm going to try not to go too quickly today. So let's jump in. Why are we still talking about ICD-10? Right? That was something that happened in 2015. A lot of people are thankful that that's in the rearview mirror. And the metaphor that a lot of people used when talking about ICD-10 was they compared it to Y2K. It was a big change. There was a lot at stake, and you had to do it all in one day. You remember this? Thursday, October 1st was the day that you had to use ICD-10. And so I think for a lot of people, that was the appropriate metaphor. But the problem is, as we've gotten past that date, a lot of people think they are safe from all of the changes required from ICD-10, that it was a one-time event that they don't have to do anything with again, right? It was a lot of hype, a lot of buildup without a lot of negative consequences. And that's true for Y2K, but I don't think that's necessarily an appropriate metaphor for ICD-10. We used ICD-9 for 30 years, and we're going to use ICD-10 for a minimum of 7 or 8 years before the CDC is able to publish ICD-11 for use in the United States. So a better metaphor than the build-up to Y2K is probably having your first baby. You know, you still have a lot of the buildup. You remember probably those 9 months of anticipation before your child arrived. This is a picture of my wife and my oldest son on the day that we became parents. And that was a big, big day. But most of the hard work of parenting happens after the day that they were born, not before. Most of the hard work of ICD-10 happens after October 1st, not before. Yes, we did a lot of planning, a lot of hard work, a lot of training to make sure that October 1st was a good day for your practice. But ICD-10 is going to continue to evolve, continue to change, and you have to change along with it. Right? A lot can change in a short period of time. Right? This is a picture of the day my son was born. You know, now 6.5 years later, our family looks a lot different. And there are some times when everything looks nice and neat, and there are some times when things look a little crazy. And that's going to be the same thing with your ICD-10 planning. Right now, it may be going smoothly for you. Right now, you may not be seeing any negative consequences about ICD-10, but there are changes on the horizon that could disrupt that, and I want to make sure that all of our clients are well prepared for that. That's why we're still talking about ICD-10, right? You remember, put yourself in the same shoes a year ago. You remember about all of the concern that people had over ICD-10? All of the consultants were telling you, make sure you've got a good line of credit in place so you can fund operating expenses for 3 months or 4 months in the case of a national meltdown over ICD-10. Medicare, CMS predicted that denials would double or triple as a result of ICD-10. And here we sit today, and the data published by CMS shows that denials have not increased at all, right? I'll share this data with you just so you can get a feel for what this looks like. CMS compares claims data from prior to October 1st, that's the historical baseline, to what happened in the fourth quarter of 2015. And you can see claims volume didn't move at all. And the total number of claims denied actually went down slightly. Probably not statistically significant. So you basically see no change in the denial rate. So what does that mean? We expected a huge increase in denials, but it didn't happen, right? In that sense, it was just like Y2K. People say, look, it was a non-event. We don't have to worry about it. It was blown out of proportion, right? And so we asked ourselves, well, how did this happen? Why did this happen? Why did we expect a big change and we didn't have that happen? One explanation is maybe ICD-10 wasn't that hard. Maybe people overreacted. Maybe people got a little scared. And I really don't think that's fair. I think that minimizes the amount of hard work that went in by administrators and billing managers, compliance managers, coders, physicians, vendors to prepare for the change of ICD-10. It's a possible explanation, but I don't think it's very likely. A second explanation is, well, maybe CMS was wrong. Maybe Medicare got much higher quality data in the claims than they had originally anticipated. And that means that physicians spent long hours memorizing all of the new 69,000 ICD-10 codes. Again, maybe there may be pockets of places where that's true, but I think when you look across the board, it's very unlikely that that explains the non-event across the entire industry. I think the most likely explanation is that the real impact has not been seen yet. The real impact of ICD-10 is still ahead of us, not behind us. And if it's still ahead of us, we've got to be careful and make sure that we protect ourselves from those types of changes, all right? And we talked about what the risk is. Do you remember where Medicare gave us that 12-month grace period, saying that they wouldn't deny for those unspecified codes before October 1st, 2016? And most of the commercial insurers are following suit. They haven't denied for those codes yet either, but we know that they will. We know that that's coming. It may not all happen on the same day. It may not all happen in the same way, but we know that that's coming. And so that's why it's important to know your data, to know how frequently those unspecified codes are being used. Looking across the country, what we've seen, the national average for how frequently unspecified codes are used is just over 30% of the time. So nearly a third of diagnosis codes that are used across all providers are unspecified codes. That is a big, big problem. That is how you could see, the national denial rate today is 10%, and they start cracking down on those unspecified codes. You can see very easily how that could double or triple for your practice. Right? That's the bad news for providers across the country. The good news for White Plume clients, most of them did a great, great job preparing for ICD-10. Most of them are doing a great job of using White Plume tools to help keep that rate lower, and you're doing 3 times better than the national average. that is something worth celebrating, right? Your practice, your processes, your people are delivering results that are 3 times better than your peers on average. Now, the average numbers are nice, but what you really want to know is, what is your number? What is your unspecified rate for your practice? And that's why we recommend running that analysis. So again, if you don't have that already, if you don't have it in front of you, if you need another copy of that, let us know through the questions panel, and we'll make sure that we get you that. And when we look at this, what we typically do is we'll show you the summary data at the top, and then we'll give you the provider by provider detail at the bottom. So at the top, you can see what the unspecified rate is for the national average, what it is for White Plume clients, and what it is for your practice. And then how that translates into denial risk, meaning if the payers denied for every unspecified code, how many new denials per day per provider would your practice see? And how does that compare to the national average? Again, you can see on average for White Plume clients, that's 3 times better than the national average, but you want to know what it is for your practice. The daily physician productivity risk, the reason we put that in there is when you use an unspecified code, if your payer requires a higher degree of specificity, that means time for the billing staff to go back and look at the note, time for the billing staff to go back and ask the provider additional questions. You know, if you assume 1 question back to the provider for each denial, and it takes 3 minutes for your physician to read, research, and respond to that question, that's how you get that daily physician productivity risk that you see up at the top and that you see for each provider in the detail down at the bottom. And then lastly, the daily cash flow risk. That uses the medical economics figure of $25 per denial, the cost to resubmit a denied claim. So we simply take the new denials, multiply them by $25, and that's where you see that figure as well. So it gives you the summary data at the top, and then at the bottom you can see each provider, Dr. Andrews, Dr. Bryant, Dr. Antonio, where you can see their individual numbers. And a lot of our clients like to share this information with their doctors to do 2 things. Number 1, show how well you're doing compared to your peers today, to celebrate that. You not only survived the transition to ICD-10, right? You were the cream of the crop in the transition to ICD-10. You were thriving. The other thing that people like to do is it shows the doctors how they stack up compared to the other providers in the practice. And some people like to get a bit competitive and see places where they might be able to improve, right? Where can they do a little bit better? And that's why another reason why we like to provide this data as well. Another part of the report that we give you will show you the most commonly used unspecified codes across your practice, so that you can start to work those top down, work the ones that are happening most frequently, to figure out how you can use more specific codes. Instead of using unspecified hyperlipidemia, you can see there are 5 other choices that are more specific in ICD-10 that you should be using instead. Now, of course, your documentation has to support this. It has to back it up. That's true in ICD-10 just like it was in ICD-9. But if you work these from a top-down, this is how you can get that unspecified rate even lower in your practice. So I recommend starting with the unspecified analysis. Get that report, get that data, understand it, understand what it means, so then we can use it to make the practice a little bit better. And that's what I want to spend the majority of our time on today, is how do I take that information and use it to make my transition to ICD-10 in 2016 as successful as it was in 2015, right? So I've done my unspecified analysis. Now what, right? Well, the first thing that I would recommend doing is working top down. Let's start at the top of that report. let's focus on your most frequently used unspecified codes before we focus on the ones that you're using very seldomly, right? Those are the ones that pose the biggest risk to your practice. If we start there, you'll get the biggest bang for your buck. Number two, you need to determine if those unspecified codes are appropriate or inappropriate. I'm going to talk more about this, but there are times when it's okay to use an unspecified code, right? You're never going to get your unspecified rate down to 0. That is not the goal. There are times when you need to use unspecified codes, but you need to determine for each one, do I think this one's okay or not for our particular practice? And that will vary by specialty. Okay? So you need to make that determination. Again, we'll do that working top down. And then for the ones that are appropriate usages of unspecified codes, you may have to push back against the payers. Right? That's what you need to be prepared to do. Some payers will take an overly aggressive stance and may deny all unspecified codes. They shouldn't do that, but you'll absolutely see some of them do that. We've already had some clients report payers in their states taking an aggressive stance on unspecified codes. The payers haven't done this before. They are learning as they go, and you need to be prepared to fight back against that. Now, if you do have places, and most of you will, where you are using unspecified codes inappropriately, that's where we want to put some processes in place to make some changes to try to prevent those, if at all possible. And if any slip through the cracks, make sure that we have a process in place to correct them. And again, the goal, as it has always been, is to protect your doctor's time, protect your doctor's productivity, and make sure that you get your claims paid completely and correctly the very first time. That's what White Plume has always done or tried to do to help our client, and we want to do the same thing here. Okay, so we talked about working top down. Let me talk a little bit, give you an example of an appropriate unspecified code. I think this might be helpful to see. One example is E55.9, right? A commonly used code, vitamin D deficiency, unspecified. The reason this is showing up on the report, the reason you may have a payer deny it, is because the word unspecified is in the description. Now, many of you who've been around for a while know that many of the codes that ended in .9 in the ICD-10 world were unspecified codes. That's not always true in ICD-10. Okay, it tends, it's not always the terminating digit that determines unspecified in ICD-10. But E55.9 is an unspecified code. If you go look up in the code book, you'll see that there are actually 2 codes that it could be in the E55 family. One is rickets and one is vitamin D deficiency. Most of you probably don't see very many patients that have rickets, I'd venture to say. And this is an example of where there are not any more specific codes in the code base right now. Now, the code freeze will be expiring in October, and new codes will be coming in. But today, these are the only 2 codes that have anything to do with vitamin D deficiency in the code book. And so if a patient doesn't have rickets, then E55.9 is the correct code to use. This is an example of you are coding correctly. There are not more specific choices, but your payer may be denying it. Because when they started to crack down, when they started to turn on all of their edits, when they started to require more detailed specificity, they took a very broad approach. And remember, we know the payers are going to do this. It's just a matter of when and how. The entire reason the payers advocated for moving to ICD-10 is they want the more granular diagnosis information. They want that data on their insured patient populations. And they're going to start denying claims if the provider community does not give them that data. So this is an example of an unspecified code that I would say is appropriate. Let's look at one that's probably inappropriate 100% of the time. M19.90, unspecified osteoarthritis of an unspecified site. This is one of those that you can see, yes, it has the word unspecified in it. The last digit is a 0, not a 9. If you go look this up in the code book, you'll find 95 other more specific choices in the code set. And this is what we've seen happens often, is you have practices that are using this as a catch-all. They're using it nearly 11% of the time. Think about the way that the payers are looking at this data, right? If there are 95 total codes, you would expect each one gets used just over 1% of the time if they were evenly distributed. But they're not. This one's being used more frequently than it should be. And it's unspecified as far as the type of osteoarthritis, right? You didn't specify whether it was primary or secondary or post-traumatic osteoarthritis. It's non-specific as far as the joint or the anatomical location. Right? Is this generalized or is it localized osteoarthritis? Osteoarthritis of the knee or the hip, the hand. And then lastly, it's non-specific as far as the laterality. And a lot of ICD-10 from an anatomical perspective includes laterality choices. So is it on the left side or the right side or both? This code is very, very vague. And it's one that I think the payers would be legitimate in denying, asking for additional detail here. If we had a face-to-face encounter with the patient, we should at least know where the osteoarthritis is, which joint and which side of the body. So I want to give you those examples because I think it helps when you're thinking about the framework. And the grid that I would use to think through this is I want to determine whenever I'm looking at an unspecified code, is it something that I'm using frequently or not? Because I obviously want to start with the ones that are being used multiple times a day in my practice, right? And we'll work top down there. And then I need to think about, well, is this something that is always okay? Like vitamin D deficiency unspecified. Or is this something that is never or very rarely okay? Like unspecified osteoarthritis. Because again, if it's something that is never okay, I want to make that type of correction. I want to be able to use the more specific code so that I can prevent the denial. Right? I want to be able to say, how do I get my doctor to choose that correctly the first time so that we can get our claim paid? And if I can't get that done the right way, how do I build a rule in ExceloSmart to identify that so that I can make the correction and get the claim paid the first time? That's an important thing to do. Let me show you just a couple of examples of how you can do that. All right. So here I am in ExceloCapture, for example, and I might have an osteoarthritis code that's an unspecified code on my form that's converting automatically to that unspecified osteoarthritis code. That means I was using that unspecified code in ICD-10 inappropriately, right? I wasn't being more specific. There were more specific choices, but there weren't negative consequences to that in ICD-10. Now, I could certainly list out all the 95 choices in ICD-10 for those codes. But what some of our clients are doing is instead, they're creating a revised custom scenario that shows them their choices, that organizes it in a way that makes sense to them. This particular practice chose to put the joint in that drop down up at the top of their custom scenario, because they know that over half of the patients with osteoarthritis, it's of the knee. So that makes it very, very easy for them to see the organization and to select the right code with the minimal number of clicks for their providers. Now, an alternate way of doing that would not be to stack them up. You could display all of them in one larger custom scenario like this. You've got a lot of flexibility with those tools. But what we're trying to do here is make sure that we get out ahead of this, right? If the payers start to deny those claims in May or June or July, we want to be taking that unspecified analysis and making these changes now, taking advantage of the extra time the payers have given us, taking advantage of the grace period to make sure that we get that done correctly. Right? I'll show you another example. Again, thinking of something that fits into the top right-hand corner of this grid that says we use this all the time, and it's something that we shouldn't really be using. High frequency, never okay. Right? I'm back to hyperlipidemia. Right? Maybe you get a pop-up that just shows these two choices, other and unspecified, because you were using the unspecified code incorrectly in ICD-10. Again, that's okay. There are not negative consequences to doing that in ICD-10. And for many of you, there are not negative consequences today in ICD-10. But we're coming to the end of that grace period. And so again, it's another change that we can make to the custom scenario to show the more specific choices. Organize that in a way that makes sense to your doctors. We recommend putting the unspecified codes at the bottom. For most people, they cannot take these type of unspecified codes off entirely because, again, there are times when it's appropriate to use that unspecified code. But look through your unspecified codes. Start at the top and work your way down. For those of you that are using Capture, this is a great way to make sure that you're getting the right code the first time. For those of you that are using your EHR to capture these charges, you need to talk to that vendor and to try to understand, are there any changes that you can make to the user interface for the physician to make it easier, to make it faster for them to get the right code. Okay. Now, regardless of which way you capture the charges, we also want to put a good mechanism in place in Smart to identify those unspecified codes, to show you the more specific choices so that we can get the right code on the front end and post that correctly into your practice management system. Right? But before I do, let me make one more comment about what to do with some of these high frequency codes that fit into the top left quadrant. It may be the vitamin D deficiency unspecified. It may be unspecified fever, right? We don't know what's causing the fever. It's viral. We're not going to treat it. They just need to go home and rest and drink plenty of fluids, and they'll feel better soon, we hope. Those types of unspecified codes are being used very, very frequently, and there are not more specific choices where you may not have the clinical information to know exactly what's causing the fever. That's an acceptable use of the unspecified code. Some of your payers may pay that. Some of your payers may take an overly aggressive approach and start to deny those. The reason I say you want to go through that and know what your high frequency, acceptable, unspecified codes are is so that you can keep a close watch on that. So if one or more of your payers start to deny that, you can respond very, very quickly, right? You can reach out to your payer and fight back and explain that it is an appropriate use of an unspecified code, and that you don't think that they should be denying that going forward. Or you can ask for additional information of how they would recommend you coding that to make sure that it is paid correctly, right? Because it doesn't make sense to do the additional tests to find out what's causing the viral infection. You need that type of guidance from your payers, and you want to find that out the very first time that it happens, because otherwise, if it's a code that you're using 50 times a day and you don't catch it for 2 weeks, that's 500 claims that have been denied that your team has to follow up on. And that's just additional overhead cost. It's unnecessary, it's wasteful. You can't change the payers, but what you can do is know your data. Know where you're at risk for this so that you're prepared to fight back if and when any of your payers do make that mistake. Okay? So just a quick review of what we're wanting to do here. We want to work top down. We want to decide, is it appropriate or inappropriate? We're going to fight back with the payers on the ones that are okay, the ones that are acceptable. And then we want to be able to prevent and correct the inappropriate use of unspecified codes. And we can do that through the custom scenarios in Excel Capture, and we can do that through custom rules in Excel Smart. Let me show you an example of what that might look like in Excel Smart. We talked about the hyperlipidemia example. Here's what I can do. I can come in and build a rule that says, when I see this code, E78.5, I want you to stop my Excel Smart user and let them know that this is an unspecified code, that there are more specific options in ICD-10. It shows them, here are my choices. It gives them the code in the description so that they don't have to go look that up. For some of the advanced users out there, you could obviously build these in as remedy codes within your rule in Excel Smart. What we're trying to do here is get out ahead of the problem, right? Excel Smart will identify when you're using these unspecified codes. It'll show you the more specific options so that your user can make the correct change, so that the claim posts correctly to your billing system, so that the claim goes out the door correctly the first time, right? You're already ahead of the game, being that your unspecified rate is much, much lower than the national average. If we take these steps, your unspecified rate can get even lower. For most people, even if you just do the top 10 or top 20 unspecified codes, you can cut your unspecified rate in half. And that makes a big difference when the payers start to crack down on this. So that's why we would recommend making the change in Excel Capture or Excel Mobile if you're using a white Plume charge capture solution. Reviewing what tools are available to you in your EHR if you're capturing the charge data through your EHR. But regardless of where you're capturing it, build the rule into Excel Smart so that you can prevent the use of the unspecified codes when they're inappropriate. Now, I know that can be overwhelming. I know everybody has a day job with a to-do list a mile long, right? When we've done this webinar in the past, we've had some feedback from other clients saying, yep, we agree with all of that, but we just don't have the time to do it, or maybe we need some retraining on how to build the custom scenarios, how to build the custom rules. And if you need that type of help, let Shelly know through the questions section. She can help you with that. But if what you'd rather do is say, you know what, I get it. I understand that we need to do this, but we're not going to find the time in our busy schedule. We had some clients that requested that, so we put together a little package that says, okay, if you need or want our help, if you'd rather just say, hey, we agree, we want this done, will you guys just do it for us? We can do that too. We'll identify the top 10 most frequently used unspecified codes in your practice. We will build a custom scenario based on that ICD-10 code that you're using to get that unspecified code so that you do have the more granular ICD-10 options. We'll also build that custom scenario based on the ICD-10 unspecified code. That way, regardless of how you design your form, you'll get the more specific choices and make that easy to do for your physicians. We'll also build the custom rule. It says this is one of those unspecified codes that you shouldn't be using. Here are the more specific choices, so that you don't have to do that work. We will include the more specific ICD-10 choices in the expanded section of that custom rule. Once we've got all of those built, we can log in to your application and deploy those items for you. Right? Now, the cost for that, for the top 10, is $2,000. That includes the entire package there. And we made a decision for the people that really kind of want to get a jump start on this, that we'll do the top 20 of those unspecified codes for the same price for the people who wanted to do that and who make that decision by the end of April. So you do have a couple of weeks on that. So if you've got questions on that or on the details of how that works, again, you can let Shelley know in the questions panel. We'll get somebody to help you with that, or you can follow up with your account executive, and they can help you get that put together. For most people, that'll cut their unspecified rate in half. So I would recommend doing that. You can do that, or have somebody on your staff do it, or if you want somebody on the White Plume staff to do it. Either way, I would just recommend making sure that it gets done. That is something that you can do that'll help your practice thrive in the continuing transition to ICD-10 in 2016. All right, so quick review before we open it up and try to answer questions. What we wanted to accomplish today. Remember, why are we still talking about ICD-10? Well, remember, ICD-10 was not over on October 1st. That's really when ICD-10 began. And the way that Medicare rolled that out, the way that they offered that grace period on unspecified codes, made it successful in 2015. But it actually makes ICD-10 more difficult in 2016, right? You will have to start using the right codes, the most specific codes, later this year. All right? I think that's the first place where I would start. The short-term and long-term risks of ICD-10, remember, the short-term risk is the denials. The payers are going to start to crack down on this. And when they do, we'll see denied claims go up. Most of you are better prepared than many of your peers for this, but there's always room to improve. Now, the long-term risk, obviously, is as we transition away from fee-for-service towards a value-based reimbursement model, outcomes-based reimbursement model, you'll need the more specific ICD-10 codes to show how sick your patients are, to maintain and maximize your reimbursement. So there's not just the short-term denial risk on ICD-10, there's also that long-term risk of those unspecified codes. Okay? And then we wanted to answer the question that says, okay, great, I've got my unspecified analysis. I see that I'm doing much better than most of my peers, but now what? Well, the first thing you should do is know your most frequently used codes and work top down, right? And then we want to take that information and then prevent and correct the unspecified codes, right? Some of them are appropriate, some of them are inappropriate. You need to make sure that you know the difference. And then you need to make sure that you make those changes in your applications to minimize your use of unspecified codes, to make sure you get the right code the first time, and to make that easy for your doctors. Because remember, none of our physicians went to medical school because they wanted to be a coder, right? We have to make that easy for them. If you don't think you've got time to do that, and rather White Plume just do it for you, let us know, and we'll make sure that we jump in and help as quickly as we can. All right? I know I covered a lot today. I do thank you for your time and hope that it was helpful